I was telling Allison that I'm amazed that this is run and organized by a group of students who have absolutely no time on their hands. They've done a great job with the conference, so I'm glad everyone involved. And Allison actually is on our board for Chronic Care International as well. So she's got obviously free time on her hands. I don't know. So I am excited to be here, and it's such a great group in the conference, such a great room of people, because just by being at a global health conference, it means you want to do good. And so it's just great to see such a group of people motivated to make a positive difference in the world. And the great thing about that is the amazing job security, because there's an infinite number of good things you can do in the world. So everyone here is in a secure position for the future. Is this recording? Okay, excellent. So I'm going to just take the next little while to talk to you a little bit about chronic disease, and a couple of them in particular. It is really kind of a three-piece agenda. One, to speak briefly about what is the chronic disease epidemic that I want to focus on. Two, who are we as a nonprofit, Chronic Care International, or CCI. And then three, kind of our new mission as an organization, or our new focus, which is patient associations, and really stepping out of the medical into the social and economic aspects of healthcare. So I think there's probably different backgrounds in the group with regards to diseases, but I thought I'd start very basic and say the two chronic diseases that we're focused on are diabetes and hypertension. As a third is high cholesterol. We don't seek out people with high cholesterol, but inevitably there are patients with diabetes and hypertension have high cholesterol as well. And so diabetes is simply that you have a tendency for your blood sugar to go too high. There's three kinds: type 1 diabetes, which is generally young people, but it can affect adults as well. They lose their ability to make insulin. And then type 2, which is 10 times more common, about 10% of the population, which is usually adult in onset, but now kids with weight issues are running into more type 2 diabetes. And they're kind of a split group. They tend to lose their insulin slowly over years, but they also have a resistance to the effect of insulin, which results in their blood sugar going too high. And high sugar over time is just harmful. It causes blindness, kidney failure, problems with your circulation, causes nerve damage, so people end up with foot amputations. Heart attacks is something that's often ignored in diabetes, but it's actually the number one killer amongst people with diabetes. Hypertension is simply that your blood pressure goes too high, and we generally talk about a blood pressure of 140/90. There's different guidelines out there for different subgroups of people, but generally that's a true statement. And it over time causes heart attacks, strokes, peripheral vascular disease, or losing the circulation to your legs in particular, and then heart failure, which is a common cause of ending up in the hospital a lot. So if you see curves of kind of the growth of diabetes, the growth of hypertension over time, they're very steep curves over the last couple of decades. And this is kind of a simplified conceptual as to why that is. And basically, chronic diseases are related to aging. So hypertension, by way of example, 50% of people who are age 50 will have high blood pressure. 80% of people who are age 80 will have high blood pressure. So it's just very common related to aging. Diabetes is also more common with increasing age. And then obesity is part of the puzzle as well. And so with populations becoming more urbanized, more mechanized, more couch-ridden, and with more access to calorie-dense, inexpensive foods, even amongst the poor, you have this new epidemic of obesity. And if you look at the U.S., about 30% of people are overweight, 30% of people are obese. If you look at middle-income developing countries, it's similar statistics. And so it's basically, if you take a human being and you put them in an environment where there's not a lot of natural activity, physical activity, and there's easy access to food, all of us gain weight. And unless you sometimes do a superhuman effort against that, it just kind of happens. And then I put this middle section just question marks because there's a lot we don't understand about the origin of diabetes and hypertension. The studies I love to listen to are about the gut microbiome, that the bacteria in your intestine have this mysterious effect on both diabetes and a lot of other determinants of health. And so it'll be interesting to see what research over the next decade shows. And so the size of the epidemic with regards to diabetes and hypertension is that there's about 422 million people in the world with diabetes. There's over 1 billion people with hypertension. So 422 million would be the entire Western Hemisphere, and 122 billion, 1.2 billion would be the entire Western Hemisphere. 422 million would probably be the US and Canada put together. And then in the world, about 55 million people die each year. 10 billion of them related to hypertension and diabetes. So about 1 in 5 people who die, it's related to diabetes and hypertension. And then there's a lot of complications that happen before people die, as far as long-term suffering and loss. About 1.8 million people, kidney failure, 1.2 million people every year. And then blindness, there's about 16 million people that are on that path related to diabetes. This is very different for those of you who went to the first keynote speaker. This is a different statistical view. Dr. Rudy kind of showed 2 causes of death graphs. One was low-income countries, one was high-income countries. In the middle is the bulk of the population of the world, which is kind of this middle-income country group. And as an aggregate, far and away the most common reason for anyone in the world today at this point is chronic disease, heart disease being number 1 by far, followed by ischemic strokes. And they have diabetes as an isolated cause of death. It looks like number 6 there. I was reading a study yesterday, the day before, that in the U.S. diabetes is really number 3 after heart disease, cardiovascular disease, and cancer. And I think the reason that was shown to be the case is because death certificates, which is what we generally use for our statistical analysis, aren't necessarily that accurate. And so if you dig deeper, you kind of run into different statistics. So in the end, diabetes, hypertension, chronic disease are what I kind of imagine as a silent tsunami. And so if you look at the tsunami, I think it was in 2004, I forget what year it was, that was in the area of kind of Southeast Asia. In that one incident, that one day, about 250,000 people lost their lives. And it resulted in billions of dollars of effort to help the people who were harmed and to just for relief and recovery. In the world, every year, 10 million people die silently of heart attacks and strokes from their diabetes and their hypertension. But it doesn't all happen in one place at the one time. So if you look at the graph that Dr. Rudy showed on where we spend money internationally in the U.S., we spend $13 billion on healthcare, which is less than 1% of the budget. I know I think it was 2014, 10 million. So of the 13 billion, 10 million went to chronic disease care, even though it's the biggest killer in the world. And so it's a non-motivating problem because you don't perceive it as a tsunami, even though it's the worst catastrophe every year, year after year after year in the world. It's silent, and so if this were to happen all at once every year, so every year everyone's going to have their heart attack and the stroke on the same day, I think you'd see a different response. You'd see the 13 billion plus going to how do we avoid this before it happens on April 5th or February 5th this year. It's a silent tsunami in 2 other respects. It's a silent tsunami for doctors because when we receive patients, I will ask a patient, how are you doing? And they'll say, oh, I feel fine. If they have diabetes and hypertension and they're even moderately controlled, they feel fine. And so I'm not very motivated to spend a lot of time on making sure they're strictly controlled. And so there's this clinical inertia where as a medical system and as doctors, we don't necessarily feel strongly motivated to go out and find the patient who hasn't come in because they felt fine. And so we fail somewhat as medical systems and because it's a silent problem to us. And then for patients, it's kind of silent. My usual interaction with a person with diabetes is asking them, so how are you? And it's always a trick question. I always say, I feel fine. And then I always kind of correct them. I say, well, I asked you how you are, not how you feel, because how you are means something different. It means how do you feel now, and also means on what trajectory are you. So are you going to feel fine in 5 years or in 10 years? And that depends on how well your diabetes is controlled, how well your high blood pressure is controlled. And so I say, you can tell me that you are good, which is the question, when your A1C, which is our measure of your diabetes control, and your blood pressure are at good levels and you feel fine. Then you're really good because you're in a good place right now and you're heading towards a good place. So it's really big numbers. And the video that was played during the first presentation overwhelmed me with regards to there's just such a volume of people, problems, and data all over the world that sometimes you just get so overwhelmed that you want to just not do anything. But there's a very individual and human face to the problem, and all of us, I think, whether it's this problem or another, are called to kind of be present to the problem in front of us and to address it, even though there's a world of problems around that we can't address. And so when I think of diabetes, I have patient after patient after patient that I have mental images of. One gentleman in the Dominican Republic came to a screening. He had a hole in his heel that was about the size of a quarter that went all the way down to the bone. His leg was red and swollen. He had a fever. He felt awful. And that's because he had had diabetes for 20 years, and it was poorly controlled for 20 years. I said, well, you really need to go to the hospital. There's nothing I can do for you here. He said, well, I was at the hospital, and they can't do anything for me. And so he was on the short path, most likely, from getting sepsis, probably dying from his wound within a few weeks of that. My daughter was in Peru doing a Creighton Study Abroad program, and her host mom had diabetes, was a single mom of 2 kids, and she was in the midst of kidney failure. And her daily question was, well, when my kidneys fail, who's going to take care of my kids? Because dialysis is $1,000 a week. So chronic disease itself is kind of expensive with regards to good control and prevention, but chronic disease complications are just overwhelmingly expensive. The woman in this picture with the cast, she was in a village in the Dominican Republic, and she has diabetes. She would get up every morning at 5:30 in the morning and walk. And you think, oh, that's just fantastic. And the thing is, they don't have sidewalks. And so a motorcyclist got a bug in his eye and swerved and hit her, broke her arm and her leg. And it speaks to the barriers with regards to how you exercise in an environment where there's no gyms, there's no safe place to exercise, and how do you eat well in an environment where it's all inexpensive, high-starch foods that aren't good for a person with diabetes. And then this kind of first phase, I've lost my toe, and that usually ends up not healing well, and you lose your midfoot and your foot and your leg. So there's just a lot of individuals who want to live good, long, healthy lives, and are in this kind of mode of, I feel okay. Should my diabetes and hypertension be a priority for me? I don't really understand them well because I don't have good access to education. One gentleman said, a young gentleman, single father, 4 kids, your diabetes is just terribly controlled. And he said, well, I have a choice. I can buy my insulin or I can buy food for my kids. And so it's hard to tell someone like that, well, you need to pay more attention to your diabetes. So, and in the end, for me, it's really a family problem, because kids, what they need is they need a healthy mother and father. And in the developing world, they need a healthy grandmother and grandfather as well, because the parents are often working. And so really the epidemic of chronic disease, and I reflect to this morning's presentation again on this, where she commented, I think it was Zambia, where the population is very young, and that population is missing mentors. It's missing people who pass on their culture, who pass on their values, and that's kind of the importance of children having parents and grandparents who are caregivers rather than people that are cared for. So that's a little bit of the epidemic, kind of at a global scale, and then individually what it looks like. As far as Chronic Care International, or CCI, we are an organization based in Omaha that was started by Dr. Philippi, who's a surgeon, and his daughter-in-law from California, who's a diabetic educator. And they had caught word that diabetes is a problem in the Dominican Republic, and got funding actually from USAID and the Chicago Cubs to try and start something. So about 2010 started this, and I joined them about 2012. And so we are working in the Dominican Republic. There's 11 of us who are kind of a working board and a one half-time salaried program manager. And then we have a 15-member team in the Dominican Republic who actually provide the care. So a Dominican Haitian team of health promoters, nurses, doctors who work in kind of the north central part of the Dominican Republic, where Creighton's ILEC Center areas. The Dominican Republic's population is about 10 million. Average income is about $160 a month. So if you earn $40 a week, $1 an hour, and your medication could cost you $30, and, the likelihood of my saying, yeah, I feel okay, maybe I could take my metformin, my medications once a day instead of twice a day. So a lot of what I see in the developing environments that are middle income is under treatment. So a lot of people are being treated, but half the time or half the dose. And so we have 2 clinics. Each one serves about 15 villages, and we have about 950 patients. The approach that we've taken is a little bit of a systems approach. So in the developing world, public health systems, the health systems in general, historically have focused on maternal infant care and infectious disease, because those are the things that affect young people that have been prevalent historically. And they've done a great job, and as a result, have essentially caused a second epidemic, chronic disease epidemic. Now people are aging in most all countries and getting to the age where they can develop chronic disease or complications. And so there's a model, the chronic care model is one of the systems models that we use as we think about how do we approach in a poor rural population in the Dominican Republic this problem that's going to last for each individual 20 to 30 years. How do we approach that? And so I want to highlight 4 pieces of this model, particularly management support, delivery system design, support information systems. The broader circles really talk about having community relationships and good leadership. So in the Dominican Republic, by way of example, the ILEC Center, which has a 4 years of presence in the country, so as a great partner, we couldn't do our work without them. We also work with the Tertiary Care Diabetes Institute that can take care of complications, so we can focus on the primary care. And so community relationships and the organization as far as leadership are very important. But these subpoints really talk more about the point of care. So when I receive a patient, how do I receive them optimally as far as their diabetes and hypertension management? And so self-management support is essential. When a patient goes to the doctor, they're spending about 0.01% of their time with the doctor. And then 99.99% of the time, they're at home deciding what food to eat and whether to watch TV or exercise. And so all the decisions that affect their care and whether to take their medications, all the decisions that affect their care happen at home. And so you have this very narrow window of time in a clinic to impact people's health. So we have a group of 9 health promoters who are all Dominican, who all live in the area of their patients, of our patients, and know them and know how to relate to them. Any one of these 6 individuals would do a much better job with a Dominican patient with diabetes than I would, because they have a different understanding and a different relationship than I do with the patients. Delivery system design really speaks to working to design a system that is efficient, effective, and takes full advantage of every opportunity you have to intervene with the patient. For diabetes, there's a test we commonly do called the A1C, or the glycosylated hemoglobin, which tells you what are the last 3 months of diabetes control. What does that look like? And 5 is someone who doesn't have diabetes. 14 is someone who has a blood sugar of 500 all the time. So really, control diabetes, we try to get people to be about 7. So it really tells you the truth of diabetes. So someone can come in and tell me, I feel fine. And if I see their A1C is 11, I can say, I am so glad you feel fine. But we need to do something differently with your diabetes, because that's not your future. And so in the Dominican Republic, by way of example, to get an A1C done is just very difficult. It's expensive. You have to go to a lab somewhere. If you go to a lab somewhere, it's after the doctor sent you there, so you may not see the doctor for 2 months after that result. and it's just not useful and not available. But we do point of care A1C testings in the clinic. The patient gets an A1C done every 3 months, and then they see the provider with their A1C result, and it's actionable right away. That's just a kind of a small example, a piece of the system you need to design in order to have optimal care. Decision support really means do you have the knowledge you need, support you need as a clinical person to make the right decisions, to make progressive treatment decisions. And so we use treatment algorithms. We try to simplify it with regards to when you receive a patient, here's the first steps, here's the second steps, here's the third steps, here's things you need to watch out for. When a patient comes in, they answer a series of about 20 questions that all are geared towards side effects for common medications and complications of their disease. And then the provider has those answers available without having to ask those questions. And all the warning signs we put into the algorithm for diabetes, hypertension, and high cholesterol. So that prevents a little bit the clinical inertia phenomenon where you undertreat patients because they feel fine, and so you don't feel highly motivated to necessarily push them in their treatment. And then clinical information systems is the last of those four, and it's really if you don't know the outcomes of what you're doing, you don't know what you're doing, and so it's really guesswork if you go into an environment and you say we're going to do an intervention and we're going to do it without data. We're going to do it without baseline data. We're going to do it without long-term data. And so we put into place just a simple access database that our doctors put key clinical pieces of information into. It's exported whenever they have an internet signal into a Dropbox. We receive it here locally, and we aggregate it and watch it over time. So this is our rates of diabetes and hypertension control. You can see that the red line, which is hypertension, we started 5 years ago with 1 in 10 patients being controlled to that goal, and now we're up to around 65%. And then for A1C control, under 50% controlled to a non-dangerous level, and now we're up around 80%. And these are numbers similar to what you see in the U.S. at this point. And so one of our first questions was really, can you obtain good chronic disease control for rural environment in developing country? And it was a question we really didn't have an answer to, but time and data have shown us that, yeah, it's surprisingly very possible. How much does all that cost? For our 950 patients, we have a budget of about $125,000 a year. The biggest part is salaries, although a salary for a physician in the Dominican Republic, our doctors are half-time, and we pay them about $5,000 a year. Our health promoters earn about $2,000 a year. And so it's a big number, $70,000 for salaries, but that's 15 people. And that's, in a sense, kind of the curse and the blessing of poverty. The curse is obvious, all the inequalities. The blessing is that it allows you to just fashion within the environment accomplish more than, say, you would in the U.S. This would be one program manager in the U.S. As far as their salary. $30,000 goes to medications. We buy generic medications and have a set formulary, and then $25,000 to test reagents. Each of those A1Cs that we do cost about $8.50, and so that adds up over time. We have raised funds from corporate donors like the Cubs Charities fundraising events. We look for people who will sponsor a patient for $30 a month, all those things to kind of put together that $125,000 budget. But we really would like to spread the program, and we would like it to be sustainable in the long run. And what we've realized is chronic disease, chronic fundraising, it's a big challenge. We struggle year after year to make the budget, and so we know that we need a different model if we're going to be able to spread this to other communities and sustain it. And so we've shifted to focusing on patient associations. And so we've got this medical model. We think, oh, this seems to be very effective. Guiding the poor can do well with their health with chronic disease as well, but we're kind of stuck with the medical model in one spot and struggling to sustain it. And so there's the question is, what's the economic model behind chronic disease care? And in addition to that, what's the social change model? because people are going to keep developing in waves, diabetes and hypertension, as long as we have these fundamental problems of inactivity and calorie-dense, inexpensive foods and pop, and all those things. And so we're really, at this point, organizationally kind of chugging along with our medical model, which we feel like is pretty well refined and good, and now shifting to ask this question: what do we do for this economic model, social change model? La gente is Spanish for the people, and it's something I hear all the time. When I'm in the clinic, people will come in with diabetes, and someone will say, "La gente me dice es muy bueno para la diabetes." People tell me that cactus is really good for diabetes, and you hear all sorts of different ideas and advice. And I would say for the first 10 years of practice, I really didn't like La Gente because they give crazy advice. I had an aha moment, and probably related to this work, where I started liking La Gente. And I like La Gente now because you give advice to someone because you care about them. And so La Gente are invaluable with regards to self-management and what people are going to do. And now my question is, how do I educate La Gente? So when they're talking to my patients, they're giving them good advice. I'm okay with the cactus, but there's other things that their advice I'm not so crazy about. And so in the end, I think the solution to chronic disease really is more about La Gente than it is about the doctors and our health program. So we have in the Dominican Republic at this point at each clinic a patient association that was formed a year ago, probably today. So it was about a year ago. And the patient association concept, I'm going to spend a little bit of time on it. Really, there's kind of three parts to it. One is to work together to generate income. And so our patients tend to be underemployed, which is why they don't have money, but they do have time. And so one premise that we're exploring is if they would give, say, 4 hours a week of their time towards income-generating activities, be it agriculture, be it chickens, be it sewing, that income could then go to support the cost of medication, salaries, and lab reagents. The second would be people with chronic disease are of the age of leadership, so their parents, their grandparents, their community leaders, they're impactful people, but as individuals, they're sub-impactful. And so our feeling is if we can organize them to be a cohesive group of community leaders, then they can really look at their communities reflectively and say, what are the fundamental problems in our communities besides chronic disease, and what can we do to impact those? And so our hope is that the patient associations can be impactful as far as transformation of communities. And then we had a couple of PhD researchers do a qualitative evaluation of our program last year. One of their fundamental findings, which for us is important, is that women with chronic disease suffer differently. If you have a family situation and the husband has diabetes, the wife will cook for him. She will make sure he takes his medications, and he will receive great support from the kids. If the woman, however, has diabetes, she's only going to cook one meal, and that's going to be the meal that everybody wants to eat. If there's going to be a sacrifice as far as cost, it's going to be the cost of her medications. And she tends to be in the home and be isolated. And so women with chronic disease suffer differently and live in isolation. And so the third part to the Patient Association mission is to connect people so that women in particular aren't isolated with their chronic disease, so that they have support, they have people they can walk with, they have people they can talk to about cooking, people that can motivate them with regards to medication adherence. So the general concept behind the sustaining and spreading with the patient association is that we've got two associations, each with 450, 500 patients. If they, as an aggregate, can, say, put into place a store where they and their families are the customers of the store, so money that they would spend where the profit would go somewhere else, the profit now becomes their own profit towards the cost of care. If they could be landowners as an aggregate, they could grow healthier foods and also use that as a source of income. They could use their other talents and skills, be it baking, be it sewing, and hopefully with that become self-sustaining. And our hope, and it is a hope, is that if we can focus the patient associations to have a little bit of a tithing spirit and look beyond their own communities, that they can perhaps help the next community start. And then in the Dominican Republic, we could perhaps spread to other communities and perhaps to neighboring Haiti, which is a different story altogether. And then we would love to be able to move to Central America, to South America. As I look at it, conceptually seems like very idealistic and crazy, and it may be. We look a little bit towards history and a little bit towards our current experience with regards to the possibility of this really working. So the history piece on 31 Toad Lane in Rochdale, England, on December 21st, 1844, a store was opening, and it was the peak of the Industrial Revolution. And so what was happening was machines were now doing what skilled labor used to do. Kids were running the machines. You had child labor. You had in England an influx of people from Ireland who were poor, who were taking over the jobs. And you had all these skilled laborers who now were very poor and suffering. And there was a physician, Thomas King, who was working kind of with the industrial poor and really burned out and frustrated and wondering, how could things be better? And so his question was, what about organizing them to form a cooperative? And so he got 28 cobblers and weavers to pay for a subscription to I think it's called the cooperative, for 2 pence a week, and over the course of 4 months put together 28 pounds, so $50, whatever the exchange was then. And with that, they opened a store 2 evenings a week. They sold flour, they sold oatmeal, they sold rice, sugar, and candles. And within 3 or 4 months, the store was open all day, every day. The families became the clients. They began to employ one another. And within 10 years' time, in England, there were 1,000 cooperatives, so the equivalent of going viral in the mid-1800s. And so we feel like that was an alignment of circumstances that could make that work. And our sense is that perhaps we have a similar alignment of circumstances now. And the things in particular that I look at in this environment is that you have a group of people who are poor with something that impacts their lives. Diabetes in particular affects every day of your life with regards to your food choices and medications and everything else. They have some time on their hands. They're all talented people. They're leadership aged. They're in a culture that loves connectedness. Latino culture in its pure form is a very connected culture. And so a year ago, we asked for our Dominican health team to put together 15 patients at one of our clinics that we could talk to and just say, what do you think about this? What do you think about organizing? And at that first meeting, 50 people showed up. They met together by themselves a month later, and there were 100 people. I met with them a month after that, and it was 130 people. And so this is they. So clearly kind of interest. And I think about, when you look at a room full of people, if this room full of people said, let's pick a problem and solve it, it would be solved in short order because it's a capable group of people. And if you're motivated to a common cause, groups do amazing things. And if you think about what we organize around problems that are bothersome enough to get you to act. So war always results in cohesiveness in a group of people to accomplish something against other people. And tsunamis result in people organizing with one another against a problem because it moves your heart. I think kind of an advantage of chronic disease, diabetes in particular, is that it's the problem that never goes away. So it's a cohesive, motivating force that never goes away. And I think putting that in an environment with people who have some time, who are naturally connected, who are talented people, gives us the hope that perhaps we can kind of grow this model over time. So we've been working with them for a year. They've have probably generated maybe $5,000 through raffles and things like that. They've named their organizations, and they have presidents and vice presidents and secretaries, and so they've got this organizational structure. In March, when we go down, we're going to have a retreat, bringing the two associations together and take next steps. So that being said, we're trying to do something similar at One World in Omaha. We have about 3,000 patients with diabetes at our clinic, and so 2 months ago, I invited just a handful of my patients and had maybe 14 people show up, and we had a meeting. And a month ago, we did another one that had 9 people, and we decided that this month, which is today, maybe we would pick officers and get a little bit of structure involved with the association, think about projects. And this last week investigated and found that they use a lot that the city owns for free in South Omaha to do gardening, things like that. So about an hour and a half ago, I had that third meeting. There was just one person there. So he's president. Which is to say, you just don't know. It takes time and experience. People vote with their feet. And so in the Dominican Republic, we have this kind of idealized model, and we don't know. But in reality, we don't have any other great ideas for how do you sustain and spread a good chronic disease care model in a poor environment. So we're interested to see what the next year shows us. We actually have a group from Mercy High School who raised money to buy a piece of land that will belong to the patients. And in a month, they're going down for their service project, and they'll work that land and plant plants, and that'll belong to the patient association. I have another friend who I convinced that he'll fund a couple of chicken coops, and so we're having actually fun with the whole experience. It's interesting. The Dominican people are just kind of happy-go-lucky and great people, and so their leadership groups for the patient associations are great people. And here in Omaha, we're kind of faced, I think, with a different question. It's a Latino culture watered down in a U.S. culture, and it's urban. We haven't done heavy recruitment yet, but so I'm interested to see as well. But when I asked our group here what they wanted their name to be, their question was, well, what did the groups in the Dominican Republic choose? And so it's also my hope that we can get kind of a cross-pollination, best practice sharing across different groups that are geographically isolated from one another. So I think and I hope that hypertension are a hidden global opportunity because if we can manage to get people to kind of unite around this concept of their chronic diseases, and then since they're united anyway, become reflective about the other needs for their community, that they can be somewhat of a transformative force. And it is the prevalence and impact of diabetes are so essential. When I was driving around the road with one of our health promoters, she was just pointing to house after house. Oh, he's got diabetes. Oh, he has diabetes, but she has hypertension, and they've got this. She was pointing about to every third house. So it is just so dense that's where I think the store concept of a cooperative could be effective, because they really represent most every family in a community is impacted by diabetes and hypertension. So that's where we are as an organization. And chronic disease is overwhelming with regards to what you do with it. And at the same time, it's a fun challenge and an opportunity to work with very good people. I'm open for any questions. I think we have 5 or 10 minutes. Yeah. It's a great question. The Dominican Republic has about 1,500 primary care clinics. They call them policlinicas, and they do, I think, great work. They do some maternal infant care, they do infectious care, they do vaccinations, and they do some chronic disease work. And I certainly ask myself constantly that question: could the public health system do this? And they are doing it to an extent. We have a young doctor who is on our staff who did a year of public service in the polyclinic and in the primary care clinic before joining us. And so it was my question to him. So he'd worked with our program for a while, and I'm like, what do you think? Could the public health system do this? What do you think the comparison looks like, the factors? And he's like, well, fundamentally, there is just a poor system of care that doesn't support chronic disease care. So they don't have funding to do blood sugars, much less A1Cs. The doctors that staff all those clinics are one-year positions straight out of medical school. So they don't have time to develop relationships with patients. They don't have time to get good chronic disease experience. They don't work with algorithms. They have a data system within the country, but they don't make the data system locally actionable. Our project manager prints out patients who are overdue for their visit every week, and our health promoters hunt those people down. And so we, on a regular basis, are in contact with the Ministry of Health in the Dominican Republic, and every time we go down, we try to have a meeting with them now, because our hope is absolutely that they can better and better chronic disease care. And I think, though, and I think that will be invaluable for them to improve, and we're hoping our relationship facilitates that. I think, for me, the patient association concept is deeper than that. It's about saying what's fundamentally wrong with our environment that leads to diabetes and hypertension, and how can we take ownership. And I think without patients taking ownership of the problem, they won't really have good control, and the problem won't be addressed at its primordial level, which is before people develop diabetes and hypertension. And so even though the public health system's in place, I see it as part of the solution, but I think the solution needs to be bigger, and we certainly have the hope, though, to be influential with regards to working with the Ministry of Health and working in collaboration as opposed to competition, and share best lessons. That's one group. Absolutely.
Hi.
Absolutely.
Model is I'm hoping to all at also have that this the issue which I is we are and once the patient gets done with it, and I don't have any money to look after that, and that is for it prevent disease for the development of suggestions come that.
Yeah, so the kind of our current health model is one that's reimbursed based on procedures and 15-minute segments. And I work at One World, being in a federally qualified community health center environment. It's kind of a little different than the private health sector in that we really have a different resource and payment model and approach things differently. And so the U.S., kind of the patient-centered medical home, has become this increasingly common concept, and that's really kind of the fundamental model of community health centers from the beginning, is how to address the social determinants of health. And by the nature of who we're working with, it's people who suffer from disparities. And one of the reasons I am intrigued about a patient association here is because what you see with diabetes control in the U.S. and hypertension as well is in the around 2000, when quality improvement really became a thing in healthcare. You had very poor control rates for diabetes and hypertension. I keep my number in my head, 30%. Everything was controlled, cholesterol, blood pressure, diabetes, to 30%. And you saw these beautiful improvement curves that took you up to about 60% for hypertension and cholesterol, and maybe 75% for getting people with diabetes out of the danger zone. And then they plateaued. And now for the last 6-7 years, we've all been sitting looking at this plateau, walking around the plateau. What do we do with that plateau? How do we get it to be higher. And it's going to take an invasive strategy. It's going to take something new. It's going to take something that's population-based, that's people-based, that's la gente-based, I think, to be able to move that plateau, because that is life outside of the clinic that's preventing that from moving higher. And so my hope with the patient association is if we get good enough buy-in that will become somewhat of a peer network towards lifestyle change and support that can hopefully trickle down to the children and can hopefully help us move that curve, and then also decrease the total population who are developing chronic disease in the long run. But it absolutely requires something outside of the clinic.
So I don't model. What if those who have it are reality often live with it, cost of it, personally, mentors in terms of, this is what you'll end up if you don't take control of your style. They become leaders, they become models. Because those of us who are healthy can say, well, the donut doesn't matter, the donut doesn't matter. So we have to face it ourselves. Partner people who make it for you.
I think connecting older people with youth and kind of mentoring and influence down in that direction strategy is an important, I think, additional layer in the long run. I always think of pumpkin and blue paint, and I'll explain that. I had a patient with bipolar disorder, and I was doing my inpatient rotation as a medical student at Douglas County, and he was admitted because he had painted himself blue, which today would land you in a rock group, but he painted himself blue and was admitted, and we had several interactions with him, and he was manic the whole time I was there, and very interesting to talk to and listen to. We had a pumpkin decorating contest because it was around Halloween, and so we had patients with schizophrenia and all sorts of mental health issues, and very creative designs. And you walk down the road and you look at all these regular-sized pumpkins. The last pumpkin was just a little tiny pumpkin that had just been dipped in blue paint. Like, whose is that? And I think about that with regards to obesity, overweight, that we're taking human beings and we're dipping them in an environment of physical inactivity and lots of calories, and every time you're going to get a pumpkin. It's just we gain weight, and the older you get, the worse it gets. And so until you change the paint color, you're not going to make tremendous headway as far as decreasing the trajectory of the chronic epidemic. And it's going to take la gente to do that, and it's going to take people who are cerebrally connected front to back, which is to say people who are a little bit older, to I think begin to impact that change culturally with regards to child rearing and what adolescents are exposed to, and the choices that you make just because culturally that's what you do.
Nature goes nature
Yeah, I haven't seen Kaiser's data on what their A1C blood pressure control looks like. I know when Kaiser puts their mind to do a population-based strategy, they're generally pretty effective. It's an organization that's got a great data and quality improvement strategies in general. And I think the healthcare piece of it is very important, and getting to adherence to medications and affordable medications, all that is essential to the first part of the improvement curve, and then you hit the plateau, which is to say that intervention alone caps out as far as its potential impact. And I imagine if you look nationally, Kaiser does as well or better than anyone else as far as their chronic disease management, because they're such an enclosed system and great population management and outreach. If with our population, we have a dashboard of improvement curves that are productivity for our providers. Are they seeing a reasonable number of patients, not a reasonable number? How many of our patients have been checked for kidney disease in the last 18 months, have had cholesterol checked in the last 2 years, have had their A1C checked in the last 4 months, and all of those started abysmally, and when we measured them, paid attention to them, educated our team about them, put processes in place around them, we've had a beautiful improvement curve on everything. And so I think there's a lot that can be done with a well-designed health system and adequate reimbursement here in the U.S. especially. And I think that takes you to a certain point with people who have a disease state. And then I think what that leaves out is the impact that really depends on the environment, both for disease control and complication prevention, and then also for disease prevention at a more primary level.
Going into living and aqueducts, the dreams, all of the systems. Are you guys working together on some of this?
Yeah, ILAC being the Creighton's program center in the Dominican Republic, they have a health promoter program that's probably 30 years old, 35 years old, with about 165 health promoters, and they are an invaluable partner for us. And so the health promoters, the 9 that we have in our program, were all ILAC trained as far as their general skill, and then we've given them additional training and education around chronic disease, diabetes, hypertension, and when we go down, we stay at the ILAC Center and then travel to our clinics. The group from Mercy High School that's going down in a month, that's through ILAC. They helped us arrange purchasing the land. So cooperation and partnerships are just really invaluable in the end to make things happen. So absolutely, we work with ILAC, and we would like to probably in the next year or two, they have an annual health promoter program to tap into that, to do a little more broad education on diabetes and hypertension. And also, if we're able to spread organizationally, we would probably do so under advice from ILAC with regards to what would be a next best community. And the communities that we select, the first community we selected was ILAC suggestion, and the second community we selected was one of the health promoters who has diabetes, her suggestion, because she lived in that community. And so it's a good question, and I think we would be foolish not to work with ILAC. Absolutely. Absolutely.
And some of the education on health in general is very work. And so how are you working at the stigma of diabetes and health? Because I had a health family at daughter line, but sometimes stigma. In regards to health, how are you working to find the hand?
Yeah, and with diabetes, sometimes people with diabetes, when they're first diagnosed, they tend to have weight loss, and so people will suspect that they have HIV, and so that'll be part of the stigma that they get. And diabetes is so prevalent that it's normalizing itself as far as, oh yeah, he's got diabetes too, he's got diabetes. So now there's so many people with diabetes, and hypertension, I guess, is less stigmatizing. To influence kind of the opinion of La Gente, for us, it's really through our health promoters and through education. And through one example of kind of the patient association, how we're trying to leverage it as a change agent, is one danger of a chronic disease program with diabetes is causing hypoglycemia. And so our treatments are geared at lowering sugar. Sugar too much cause hypoglycemia. And here, if that happened and you weren't responsive, you'd call 911. In 15 minutes, you'd have an IV going, or you'd have a glucagon shot. In the Dominican Republic, in a remote campo, where there aren't ambulances to begin with, you're just kind of out of luck. And so it's a real way that, and it's an important thing in general with regards to interventions. When you go to do medical interventions in places, you just have to ask, what potential harm could I be causing? And that's definitely for diabetes 1. And so we have a very simplified educational sheet on hypoglycemia that has slots to put family members' names. And so we're using the patient association to get every patient's family and neighbors educated on what is hypoglycemia and how do you respond to it. Because if you respond early, you can do oral sugar and people will be fine. And so using the patient association as kind of the outreach tool to La Gente, in that case, in a very specific way, but really the same model applies for kind of all the lessons that we'd like to spread and kind of the cultural myths around disease that we'd like to alter. I'm impressed everyone stayed awake last talk of the afternoon, so nobody's sugar went down, which is good. So thank you all very much for coming, and good job on the work.